Hi and welcome to the next Radiology Snapshot series session. This time we're going to focus on abdominal radiology, and once again it's been reviewed by Dr. Hina Chottai. So to start with, we're going to address the 369 rule, which shows you the upper limits of the normal diameter for each of these structures. So as you can see, small bowel is 3 centimeters, large is 6, and then the cecum is 9, with the appendix, the upper limit being around 6 millimeters. So this rule is really important to consider when we're looking at bowel obstruction. And in this case, we've got some small bowel obstruction. So as you can see, the majority of the bowel loops located centrally, and they're obviously distended. We can also see the valvae coniventes, which are the small bowel folds throughout the bowel wall. These start after the second part of the duodenum and are commonly seen in abdominal imaging, so they can help reference and orientate you. Now, if the patient is having an erect chest x-ray, you may see a fluid level within the bowel due to the obstruction. Although you won't necessarily see this in obstruction, as you can present with a gasless bowel. Another presentation is the beads on a string sign, which is due to small pockets of gas within a fluid-filled bowel. Additionally, we can also see large bowel obstruction. So as you can see, the very classical, very large dilated loops of large bowel, and often there will be a very defined cut-off point where the obstruction starts, with subsequent backfilling of the bowel. Additionally, in this presentation, you may also see cecal involvement, and if you see a cecum which is 12 to 15 centimeters in diameter, then that is starting to present an increased risk of cecal rupture. So now we can move on to the different causes of bowel obstruction that you may be able to see on abdominal imaging. And the image on the left is showing an ultrasound of an inguinal hernia, whereas the image on the right is showing a CT of an indirect inguinal hernia that has been done for planning prior to surgery. So obviously with these images, you're unlikely to be able to fully appreciate a hernia on an X-ray image. And the ultrasound is probably going to be your imaging modality of choice for hernias, although they are user dependent, and CT will normally be done as a planning stage. Another cause of bowel obstruction is volvulus. So this occurs where the loop of bowel twists around itself and the mesentery that supplies it to form a bowel obstruction. So on the left we can see the very classical coffee bean sign, which is a sigmoid volvulus. Whereas on the right we're showing an image of a cecal volvulus. So you can see some dilated and some redundant loops of large bowel, and there's no small bowel involvement, which is going to be suggestive of a cecal volvulus. So cancer is another cause of bowel obstruction, and this can be directly secondary to colonic cancer or indirectly in the form of omental metastasis from other tumours such as ovarian cancer. When presenting the radiograph, report all the main findings and suggest a CT to further evaluate, remembering to recommend a chest CT for staging if you're suspicious of malignancy. This may also be followed by a PET scan if required. So there are various different ways of staging these cancers, and the TNM staging is a very common staging method that's used and can be used for any cancer. And a more specialised staging method is the Dukes or modified Dukes, which actually takes into account the invasion into the bowel wall, and you can see the summary slide taken there. So another abdominal presentation is that of diverticulitis, and this is the process where you have inflammation or infection of colonic diverticulosis, which is infection or inflammation of diverticula. So it can be one or multiple of these outpouching of the bowel walls. And the imaging of choice for complications of diverticulitis is CT. And on these imaging, you may see thickening of the bowel wall, pericolic stranding. You can also see perforations or abscess formation. And further complications include fistulas, such as a vesicofistula, where you have a fistula between the bowel and the bladder. And treatment will depend on the progression of the disease and the nature of the complications present. We can then move on to our inflammatory bowel diseases. So you can see an example of Crohn's disease on the left and ulcerative colitis on the right. Once again, these are going to be relatively difficult to distinguish based on abdominal radiographs alone. So you will commonly want further imaging in the form of potentially a CT to fully assess these. With Crohn's, they will have lesions throughout the entire GI tract from mouth to anus, and additionally it is characterised by the presence of skip lesions and discrete ulcers, in comparison to ulcerative colitis, which will most often 95% of the time involve the rectum. And you may also see some mural thickening or thumb printing in some cases. Additionally, ulcerative colitis can lead to the complication of toxic megacolon. An important presentation of inflammatory bowel disease is that of toxic megacolon. Although the term toxic colitis is now preferred, as the colon is not always distended. So this will commonly affect the colon though, most commonly the transverse colon, and a distension of 6 centimeters will often be seen, again referring us back to our 369 rule. And you can also see thumb printing, which will be a sign in keeping with inflammation. And there will be a high risk of perforation in these cases, which, if occurs, will demonstrate a pneumoperitoneum. So treatment will often be a mixture of supportive and surgical measures, so it's very important to escalate to seniors as soon as you suspect or see this. So in some severe cases we can see bowel obstruction, which, as you can see on the X-ray, is demonstrating Wriggler's sign, or the double wall sign. So there is gas outlining the bowel wall as it's both inside and outside the bowel. And this pneumoperitoneum can be as a result of perforation. It could also be as a result of recent instrumentation or recent surgery, and it's an important sign to understand and be able to identify and discuss in OSCEs. So now we can move on and consider some of the other systems that you might identify an anomaly in on abdominal imaging. So, for example, that of renal stones. So as you can see on the left, we have an example of a staghorn calculus, and on the right, we have an example of severe hydronephrosis. And it's important to consider plain films when reviewing these patients, as the radiopaque stones will be visible on your image. And there are 3 main places for the renal stones to become impacted. So that's the pelvic ureteric junction, so the PUJ, the pelvic brim, and the visco-ureteric junction, so the VUJ. And often your treatment plan will depend on how large the stones are, how far they have passed within the urinary tract, and whether there are any signs of complications. So for example, are there any signs of urosepsis or hydronephrosis, as these may impact your potential treatment plan. So our final condition that we are going to consider is intersusception, and this is commonly seen on ultrasound. So on the left you've got an example of a target or a donut sign, and on the right you've got an example of the pseudo-kidney sign, which is formed due to the longitudinal appearance of the intersusception representing kidney. And this condition occurs when the bowel telescopes inside itself, and this is commonly a paediatric presentation, but can occur occasionally in adults. So when it's presented in adults, it's often transient. However, in children, they often require reduction. So this will usually be by an air enema if the patient is stable, otherwise a surgical intervention will be sought. These are the references that we have used to help create this teaching session for you. Thank you very much for watching, and please don't forget to fill in the feedback. It really helps us create these sessions for you in the future.